Sounds like a great drink number.
It's not me, is it?
No,
Are you?
no. He's like on the side. Oh God, it is.
Wait, I want to share with the class.
Oh, I've seen that, yeah.
Big screen, big
Next
screen.
ring.
I think that's AI. I think so. Yeah.
No way.
No, I'm not in that. Yeah, he said to send it to me.
I wasn't even on that hillside that day. Welcome back. Everybody have a good lunch. I did. I did. Huh? 2 children.
Did you hear that? Someone
What?
said you eat, and then right after.
Ever read Hansel and Gretel?
Somebody else said 2 children.
You ever read Hansel and Gretel and they're push me, pull you?
Yeah.
You all know what that is, right?
Wow, we did see him at Pilot.
Didn't learn anything else in the EMT class. All right, so paramedics think that one of the most important things about being an EMT is setting up ALS interface for the paramedics. They're basically useless without EMTs, and that is very true. So as an EMT, you were able to set up and do all the things for a paramedic. You just can't actually turn the monitor on or actually stick the needle in the patient. Questions so far? So we're going to teach you how to do those things. So we're going to learn about cardiac monitors, lead placements. So there are 4 leads, which is your standard cardiac monitor lead placement. Then there are 12 leads, which are actually 10, as somebody brought up, because 2 of them have double roles. So we're going to go over limb leads, 12 leads. We're going to go over programming. Now, the program video we have is on an old obsolete monitor, but different manufacturers have all different ways of doing it, but the basics are the same. You have to put in the patient's last name, their first initial, and their age. That way, when hospitals have multiple ambulance sending EKGs, they know which one the EKG is for. You can't send them an EKG without the name and the age. All right, limb lead placement. The right arm lead goes on the right arm. This is difficult stuff, it's why paramedics got to do it. The left arm lead goes on the
Right on.
Right foot? Yeah.
left arm.
Yes.
You almost had it right. Just missed arm. The left leg lead goes the stomach, yes. The left leg. And the right leg lead goes to the right leg. Now, you will see sometimes people will put them in close proximity. They can put them on the chest, on the abdomen, but right in the same proximity of the legs. Now, they are color coordinated, so you're not trying to read the little tiny RL, LL. So the right arm is white, left arm is black, left leg is red, right leg is green. One of the ways to think of it is smoke over fire, white goes to right, and green's the only thing left over. Somebody have one for green, I don't remember what it was.
I go white on right, silver trees, smoke over fire.
That works too. Any questions about leg leads? So this gives you 6 vertical views of the heart. Then we have 12 leads. You can also set this up. The 12 leads also very simple. You go down to the 3rd intercostal space, which is between the 3rd and 4th ribs. You count down from the sternum. First ribs are behind your collarbones. 2nd, 3rd, 4th. You go between the 3rd and the 4th. Put V1 to the patient's right of the sternum. V2 goes to the patient's left of the sternum, 3rd intercostal space. Then you put V4 directly underneath the nipple, which is 4th intercostal space. If you have to, lift the breast up with the back of your hand, never the palm. And then put 4 there. 3 goes between 2 and 4. Then V6 goes at the exact same level, but at mid-axillary line as 4. And then 5 goes between 4 and 6. That's how you set up a 12 lead. It is truly that simple. Any questions? For those of you that are visual learners, we have visual. Well, you can tell that she's got a cardiac condition because of the color of her skin. Skin signs are everything. Yeah, she's a little malnourished there.
To properly apply a 12-lead EKG to a patient. We're gonna start off with the 4 limb leads. We normally put on the limbs, but of course, our model here today does not have limbs. We're gonna use his shoulder and his lower abdomen. We're gonna take the right arm lead, which is white, and we're gonna put it up right above the right shoulder there. We're gonna take the left arm lead. And we're gonna put it right above his left clavicle and left shoulder there. And we're gonna take the left leg lead. If he doesn't have legs, we're gonna put it right above the pelvis on the soft tissue there. And then on the equal opposite side, on the right side, we're gonna take the green one, which is right leg lead, and put it right there. Now we're ready for our V leads. First thing we have to do, we have to hook up our 12-lead cable. Now you notice there's a cap that goes into that. Cap's critically important because the pin holes in here and the pins are extremely fine and delicate. So if any dust gets in, they get bent, they break, and then the entire cable doesn't work, which is also a very expensive mistake. So as soon as we unplug a 12-lead cable, we always plug the cap back in immediately. We want to leave this open air as little as possible. So we plug our 12-lead cable in. Then we start with our V1 lead. Our V1 lead is a red lead. We put it on the third intercostal spot, just right of the sternum, above the nipple line. V2 is our next lead, it's yellow. We put it on the opposite side of the sternum from V1. Then we take V4. We actually skip over 3 and go to V4. V4 is a blue lead. And we're going to put that at the fourth intercostal space, which is just below the nipple, which also happens to be mid-clavicular. Next one we're going to take is V3. V3 is going to go directly between V2 and V4. Our next lead is going to be V6, which is purple. V6 is going to be at the fourth intercostal space, same line as V4, but straight over to the mid-axillary line, which is the center of the armpit. And our last lead that we're going to put on is V5. V5 is orange, and it's going to go halfway between V4 and V6. You have now successfully applied 12-lead EKG.
Any questions from that excellent demonstration?
No.
No, not nearly. Should be retired by now. So to be a print, there will be a print button. It'll either say print, recorder, depending on the manufacturer. You press the button, it prints. Cardiac monitors do not have ink. They all run on thermal paper with a heated stylus. You never run out of ink. You don't have to worry about that. If someone's telling you that they're low on ink or it's not printing on the ink, there's one of two things. Either one, the battery's almost dead and it can't generate heat from the stylus, or two, you're in such cold environmental conditions, the stylus isn't heating up enough for the thermal paper. Or three, you put the paper in backwards and the thermal side's not there. Any questions? So when you take a 12-lead, you'll hit the 12-lead button. Then you'll go to your patient info button. You'll select the gender. And yes, that is important because the way that it interprets it, the females generally have more fibrous tissue than males, and it can generate a different way for the computer to interpret it. Then the age, same thing, above 45 and below 45, it interprets the algorithms differently. And then you're going to put in the last name and the first initial. Any questions? And depending on the type of monitor it is, there's different ways of inputting data. And then you hit the acquire button, which only the paramedic can do. You can do everything up to that. You cannot push the acquire button as an EMT. So then the paramedic has to push the acquire button. Tell the patient, hold still.
Why?
Huh? Why what?
Why can only the paramedic button?
It's called politics and lobbying, because the union's paid to make sure that EMTs can't do that, because then why would you need paramedics?
I'll read it. Are you for another?
Same reason why paramedics can take dopamine drips in the field, start them in the field, but they can't take IV antibiotics, because then you wouldn't need nurses for transfers. It's called lobbying and politics. There's no logical reason. It's not about patient care. That'd be silly.
We might sheep of that.
I mean, if you push a choir, it could kill the patient. That's why. Come on. So anyway, yeah, sadly, that is the reason. It's ridiculous. Even an EMT advanced can't do that. They can start IVs and they can push up an effort and they can give all kinds of drugs. They can't hook up a cardiac pump.
I'm really thinking my life.
Rethink who you vote for.
Yeah.
Any questions?
We're need some good options on the better options.
How much money they're taking from unions, then you'll understand things. All right, any questions? And then once it's done, then you transmit it, you select the hospital you want to send it to. Make sure you have a good connection. Most of them are internet based now. You gotta have a Wi-Fi connection, or else it won't work.
Are we allowed to tear the paper off?
Yes,
Okay.
you're allowed to put the paper in too. You're allowed to reload the paper.
Big one.
And you transmit the EKG. Any questions? This is a very, very difficult job.
Are we gonna get a chance to play with some of them today?
Yeah, we actually have some.
Okay, so what we're gonna do here is learn how to obtain and transmit a 12 lead EKG using the Zoll E-Series monitor. So the first button after we've hooked our patient up to the 12 lead, we're gonna push is the 12 lead button. That'll bring us to the 12 lead monitor screen. The next button we want to push is acquire. So your 12 lead will be acquired. And at that point, you want to decide which hospital to send it to for your choice of hospitals. You can use the arrows on top of the monitor, up and down, to select which hospital you want to send it to. Then all you have to do is hit the transmit now button. You will see it will go through a series of screens retrieving the record. And at this point, it's completely automated. All you have to do is keep the phone within a short distance of the monitor.
Goes a lot faster than that now.
About 10 feet. And you can continue working on your patient, and it will take care of all this for you. Transmission completed, it will tell you transmission completed, which you may not even notice because you'll be working on your patient. And you have successfully taken and transmitted 12 lead EKG. Thank you.
Any questions?
Action.
Do it on a live patient.
Can't see your face, just a glove. You go ahead and explain what you're doing as you're doing it. Right arm lead to the right arm, left arm lead to the left arm. Right leg lead just above the right leg. Left leg lead just above the left leg. V1, counting the rows down. 1, 2. Use the back of your hand to lift the breast up.
I already count though, so. So it'd be like right here.
That would be below the nipple.
So. Like that.
Perfect.
That's it, kind of. Okay.
Always use the back of your hand. It is never appropriate to top a field.
To Mercy?
Mhm. Use the 12 blue button. No. Patient info. It's already male.
How old are you, sir?
25.
All right.
Go space them. You. And return.
No.
And we on the whole stone, take a breath. Okay. Perfectly healthy young man. Okay, so now you want to transmit to Mercy out chest. You can just do that while it's printing. At this point, you can walk away from it and you're treating your patient.
Okay.
You'll see though, it'll say transmitting.
Oh, I see that.
He's screwing with it. He's intentionally bagling down and bringing his heart rate up and down. He's a smart ass.
Oh, yeah.
Yeah, so there he goes. He just bageled himself down intentionally.
Yeah, I'm from the
Any questions? All right, that pretty much encompasses how to do a 12 lead. That was pretty brutal. You guys able to get all that down? I know it's not,
It's a lot.
it's a lot. As long as you don't hit the transmit button or the acquire button,
Hit the button that they.
you guys will be okay.
See, I feel like I have to hit it because I was so not pushing. Right?
Yeah, but then the patient detonates.
Well, then it won't matter. 'Cause we'll all-
Unless you have a paramedic card.
like
Hold on, it's got that.
All right, so same thing. So you guys can set up an IV line and have everything ready to go, just you cannot stick a needle inside the patient's vein.
That makes more sense. Have you guys something?
So here's our bag. We're gonna pop this off. Now we have our spike. We're gonna take this off. So what we're gonna do now is we're gonna come over here and we're gonna spike our bag. Spike that up.
Make sure it doesn't touch
Perfect.
anything.
We can see the fluid running down there. I'm gonna get my chamber just to about probably halfway full. Now, a quick tip, I can go like this, bring it right over here. Now, I wanna get all my drops out of here. That's what my goal is now. I wanna get all these air bubbles, all these drops out of here. So we're gonna go ahead and do that. They're coming along nice. And then let's just say that all the air bubbles are gone. We got a few more. Let's say they're done. Now I can just make it go like this. And then this is gonna connect to your IV catheter, your saline lock setup. Follow my page here. I go over all of it.
What's wrong with that video? Anybody notice?
He spiked it upward.
No, that's fine. You can do that. It's got a seal. Look at the cabinets. This is a prop ambulance. There's no equipment on this ambulance.
So here's our bag. We're gonna pop this off. Now we have our spike. We're gonna take this off. So
It's a prop ambulance.
Okay, so for today, I'm going to be just demonstrating on how to set up an IV. So the things that you want are some IV tubing and a bag of normal saline. And you've probably gone through your rights by now and making sure it has a good expiration date. Nothing is in the bag and everything is still sterile technically. So what we're going to want to do is take your bag of saline. And there's a little notch in that top. Just rub it all on the top like that. Now, this is your administration set. So tear it down just like that. Try and keep everything bundled up because it'll make things easier. You're going to want to lock your IV tubing down. And there's a cap on top of the drip chamber right here. Pop that off, throw it away. And there's a blue top tab right here on the saline. You're gonna want to pop that off. And with the bag upside down like that, insert your administration set in. Turn this upside down. Fill up your drip chamber by squeezing it like that. And trying to maintain sterility. Don't let your tab hit the floor. So we're going to open it up just like that. Going to open your IV tubing up and see how it's dripping at the very bottom. That's good. We want to extract all the air bubbles. And once you're ready, close it off. And hang it up and administer to your patient.
Like he was doing something bad and watching.
What?
Kept looking up none of it.
He's waiting. He's in a zoo. Are you kidding? Make sure the gorillas, the tigers didn't get out. I'd be a little nervous too.
I know, it's something else. is
What's that?
going on.
Exactly. You don't want another Christmas Day at San Francisco incident.
IV access to a patient provides us with one of the most direct routes for patient treatment.
It's exciting.
Fluid and medications can be immediately introduced into the body through the circulatory system when performed correctly, and it can be one of the safest, most effective methods. An important point to remember is making sure you prepare all the necessary equipment and supplies before you begin. Sharps container, tape, or another securing device for securing the IV, antiseptic swabs per your local protocol, gauze pads, site dressings, a latex-free tourniquet, appropriate size catheters, of course, based on your patient's needs, and a Band-Aid. Your preparation in advance will help you achieve a safe and sterile intravenous catheterization. Select the appropriate IV solution, double checking the expiration date, color, and clarity. Administration sets generally come in two sizes, 60 and 10 drop sets. The appropriate size is determined on your protocols and patient's medical condition. To open your solution, tear the outer packaging at the pre-cut slit on either end of the bag. Recheck the clarity of the solution and expiration date. Whenever possible, the IV bag should be hung in a vertical position with the tail ports extended downward to facilitate the preparation. Open the appropriate administration set based on the patient's condition. Be certain that the end caps remain in place to preserve the sterile field of the administration set. Uncoil the tubing in preparation for spiking the IV bag, and if adjunct devices such as extensions are to be used, it should be opened and attached to the administration set at this time. Move the flow control clamp to the closed position and place it in a convenient location. Grasp the IV port just above the plastic tab, and with the other hand, pull the plastic tab from the port, being careful to maintain sterility of the port itself. Remove the protective cap from the IV tubing spike and insert the IV tubing spike into the IV port by pushing with a twisting motion until the spike punctures the seal of the port. Squeeze the drip chamber to fill it approximately half full of fluid. Open the flow control clamp and allow the IV fluid to completely fill the line. It's often necessary to invert or flick the med ports to remove larger air bubbles. Once the line is completely filled with fluid, close the flow clamp and place the primed line in position for use. A second method for spiking an IV bag consists of inverting the bag so the tail ports extend upward. Grasp the IV port just below the plastic tab, and with the other hand, pull the plastic tab from the port. Remove the protective cap from the IV tubing spike, and insert the IV tubing spike into the IV port by pushing and twisting the spike until it punctures the seal of the port. Invert and hang the bag so it's in an upright position. Squeeze the drip chamber to fill it approximately half full of fluid. Selecting a venipuncture area usually involves the hand, wrist, forearm, or antecubital space. Inspect it for contraindications for venipuncture. Applying a venous tourniquet may help facilitate finding the appropriate site. When selecting a vein for cannulation, it may help to reapply the venous tourniquet approximately 4 to 8 inches above the selected area. Cleanse the intended venipuncture site with a suitable antiseptic swab in an outward motion for at least 2 inches. Allow the alcohol to dry for 30 seconds for bacteria to be killed and to minimize the discomfort to the patient. Based on the intent of the IV and the size of the vein selected, choose an appropriate size IV catheter. Remove the catheter from its packaging and the protective sheath. Remember to be careful to maintain the sterility of the needle and the catheter and visually inspect the end for any defects such as burred edges. As an optional step, slightly twist the catheter to ensure the catheter moves freely on the needle. Grasp the patient's extremity near the area where the IV will be started using your non-dominant hand in order to stabilize the vein. This may be accomplished by either pulling traction distally or holding the extremity circumferentially so the area is taut. Ensure that the bevel of the needle is facing upward in relation to the patient's skin. While continuing to apply traction to the skin, quickly but carefully enter the skin with the needle. A pop may be felt as needle enters the vein. In this alternate view, the flash chamber fills with blood when the needle enters the vein. Slowly advance the catheter along the needle until the hub meets the patient's skin. Palpate the end of the catheter beneath the patient's skin and occlude the vein with direct pressure. Attach IV tubing to the catheter hub, making sure not to push the catheter further in or pull it out. After releasing the tourniquet, open the IV flow clamp and observe the flow of fluid into the drip chamber. With the IV running and before securing the IV in place, inspect the venipuncture site for signs of infiltration. If an IV cannot be made to flow properly or infiltration is observed, discontinue the IV immediately. If the IV is observed to flow properly, using a gauze pad as necessary, wipe away any fluid or blood that may be present in order to dry the site sufficiently that tape will adhere. Secure the IV and the IV tubing in place. Cover the insertion site with a sterile dressing or a commercially available device. Many taping methods and commercial securing devices are available, but follow your local protocols. Adjust the flow rate by closing the flow clamp or other flow metering devices to the appropriate setting, and continue to monitor the patient for signs of fluid overload, other complications resulting from the IV, maintain the appropriate flow rate, and watch for infiltration. Some protocols may require you to initial and date the IV cannulation. Selecting a venipuncture area usually involves the hand, wrist, forearm, or antecubital space. Inspect it for contraindications for venipuncture. Applying a venous tourniquet may help facilitate finding an appropriate site. When selecting a vein for cannulation, it may help to reapply the venous tourniquet approximately 4 to 8 inches above the selected area. Cleanse the intended venipuncture site with a suitable antiseptic swab in an outward motion for at least 2 inches. Allow the alcohol to dry for 30 seconds for bacteria to be killed and to minimize discomfort of the insertion. Based on the intent of the IV and the size of the vein selected, choose an appropriate size IV catheter. Remove the catheter from its packaging and protective sheath. As an optional step, slightly twist the catheter to ensure the catheter moves freely on the needle. Hold traction distally or circumferentially so the area is taut. Ensure that the bevel of the needle is facing upward in relation to the patient's skin. While continuing to hold and apply traction to the skin, quickly but carefully enter the skin with the needle. A pop may be felt as the needle enters the vein. The flash chamber should fill with blood when entering the vein, but remember, patients with poor perfusion and small catheters will be slower to show a flash. Slowly advance the catheter along the needle until the hub of the needle meets the patient's skin. Palpate the end of the catheter beneath the patient's skin and occlude the vein with direct pressure. For blood draws, leave the tourniquet in place. Apply the vacutainer to the catheter hub and use the flanges on the container to facilitate pressure when inserting blood tubes. Secure the vacutainer while switching blood tubes, and after each blood tube is drawn, gently mix the tube. However, follow your local protocols on blood draws. After releasing the tourniquet, palpate the end of the catheter beneath the patient's skin and occlude the vein just proximal to the end of the catheter with direct pressure. With your free hand, remove the protective cap from the end of the IV tubing and attach it to the catheter hub, making sure not to push the catheter further in or pull it out. Open the IV flow clamp and observe the flow of fluid into the drip chamber. If the IV does not flow, ensure the tourniquet has been released and carefully adjust the catheter while observing the drip chamber, since the tip may be occluded by a valve or the side of the vein. With the IV running, and before securing the IV catheter in place, inspect the venipuncture site for signs of infiltration. If the IV is observed to flow properly, wipe away any fluid or blood so that tape will adhere sufficiently. Secure the IV and the IV tubing in place. Cover the insertion site with a sterile dressing or commercially available device. There are many taping methods and commercially securing devices available, so follow your local protocols. Adjust the flow rate to the appropriate setting and continue to monitor the patient for signs of fluid overload or other complications resulting from the IV. Select and inspect the IV solution. Open the outer packaging by tearing the pre-cut slit at either end of the bag. Check for clarity and the expiration date. Shut off the flow clamp on the nearly empty IV bag to prevent air from entering the IV tubing as the solution bag is being changed. Invert the empty bag to prevent any remaining fluid from running out, then remove the IV tubing spike from the bag, using extreme care to ensure the IV tubing spike does not touch anything to contaminate the sterile field. Follow the methods previously described to puncture the new solution bag. Discard the used solution bag after noting the approximate amount of fluid remaining, if any. Finally, re-establish the IV flow rate. When discontinuing an IV, we should first close the flow clamp of the IV administration set. Gently remove the tape and/or securing device to expose the venipuncture site. Cover the venipuncture site with a gauze square and apply gentle pressure as you remove the IV catheter. Inspect the catheter to ensure it's complete, noting any abnormalities. Affix an adhesive bandage that will continue to apply pressure until the bleeding has stopped. And as always, properly dispose of all materials and monitor the venipuncture site for further bleeding.
Questions? That was exciting. Are you guys okay?
No.
No, it was pretty traumatic.
So. He connected the extender part that you're talking about, is that the J loop that you attach with the IV?
Depends on what protocols you have, what areas. Some people do J loops, some people do Ys. Some people just do extenders. It just depends on where you work.
For, I'm gonna have to go.
For
pulling blood back, cause I don't know how much that's safe, we can have those.
They use vacuum containers, just like they did in that one. You can also use a syringe, but
That's what I was thinking, like to flush it.
do that.
Is it just dependent on protocol?
Yep. Chefs, they generally don't do it in the field because it doesn't go into their system. It's gotta be digital with barcodes. They don't have the ability to generate their barcodes through their system, so they just make it. So, as EMTs, you will be able to take interfacility transfers of pre-existing IVs, not that one, of isotonic solution. Should be normal saline, D5W, and lactated ringers. And you'll be able to monitor their drip rates. So you can just watch the drip chamber, count the drips, know how much you're getting. And that is the formula, how many millimeters per hour. So like if it's 100 milliliters an hour, and you're using 20 drop tubing, that's how many drops an hour? 20 drops per milliliter. That's 100, 2,000. The 2,000 divided by 60 is. Here we go. 32. So be a drop every other second. Make sense? Or did I lose you?
Got me.
I wouldn't even use that formula, but that's what they teach you.
Tell me how you said that again.
All right, 20 drops per milliliter for your tube. It could be 20 drop, could be 15 drop, could be 10 drop, just depends on where you're working. Could be 60 drop. But if it's 20 drop tubing, which seems to be the most standard nowadays, 20 drops per milliliter, you have to give 100 milliliters an hour. So how many drops is 100 milliliters? 20 drops is 2,000, then you divide it by 60. Any questions?
One more, 100. I didn't even.
So if you're calculating drip rates that you want to really refine, if you use 60 drop tubing, it makes it really easy because 60 seconds in a minute, 60 minutes in an hour, 60 drops in a milliliter. Makes your math much easier for anybody that struggles with math. There's some formulas for you. So using 10 drop tubing? Yeah. So 150 drops an hour, 1,500 drops, 25 drops a minute, still a drop every other second. Any questions? Unless you're a nurse, and if you're a nurse, you have to use a pump because you can't do the math. You could tell a nurse I said that too. Look at that, 34 drops. I said 32. I was wrong. I was doing it also off the top of my head.
Killed the patient.
Detonated them. Any questions? All right, innovation. Endotracheal innovation is a high stress job. They're trying to take a tube instead of an eye gel and get down inside the patient's larynx and put a tube directly into the larynx instead of putting it into the esophagus, then inflating a balloon inside the vocal cords. Pretty tricky way of doing things, but you're allowed to set up for it, but you're not allowed to actually put the tube inside the trachea.
Didn't you used to teach us how to do this?
Huh?
Didn't you teach us how to do that 10 years ago?
Yeah, because it was in Lake Shastita.
All right, guys, what we're gonna do right now is just go
Anymore.
over a bit of the equipment that you're gonna require for airway management. First and foremost, I think it's imperative that if you are the one doing the intubation, it's your responsibility to actually check your equipment. Assemble it, check it, and be sure of the operation so that when you are actually doing your intubation, you know if anything is working properly or not. The setup of equipment is gonna be first off collecting everything that's gonna be required. So you can always do this while your patient is pre-oxygenating if it's not an emergency situation, or even prior to if the patient has arrived, if you know preemptively that you're going to do some intubation. First thing you're gonna get for yourself is a resuscitation bag. I always do a quick check on my bag to make sure that it's actually holding pressure. I include the end, push on it, see if the pop off goes off, close the pop off, we'll squeeze to make sure it's holding any kind of pressure. And we can even do a negative pressure check on this, but I'll show you that in lab if necessary. Next thing I'm going to do is look at my actual instrumentation for laryngoscopy. So you're going to need a handle with operating batteries, a blade that actually fits the handle. So I'm using a standard handle, standard blade here. This is a Mac 3. I want to actually make sure the bulb is nice and tight on the distal tip. Flip it on and check that the light is actually working. And then it's bright. Use that resolution. I have a number 4 blade if I'm unsure of the insertion depth, so I can have to check that. Look at the bulb, tighten it, make sure that it's working appropriately. I'm going to leave the number 3 blade on as that's the most common one. I'm going to leave it in the disengaged position. Next thing I'm going to do is check my endotracheal tubes here. So I've got a number 7.5 and a number 8 for my adult male patient here. So I'm going to pair both of these. What I'll do is I'll get a cuff inflator. And while it's in the package, generally what I do to kind of keep it clean is I'm gonna insert a couple cc's, probably 10 cc's or so of air into the cuff. Make sure that it's holding pressure. So insert, and basically just squeeze on the cuff to ensure that it's actually holding. You want to deflate all that air all the way back out so that when you are using that tube, it's not going to cause any kind of obstruction of your view or have difficulty going through the cords itself. So I would do that with both tubes. Next thing I would do is look at getting the stylets. Stylets are great to assist for any kind of intubation attempts, especially if you don't know if the larynx is anterior or not. Lubrication is going to be a good idea to just slightly lube up the stylet. You can use some gauze. And very briefly, or sorry, very slightly, you can lube up the distal tip of the endotracheal tube as well. Thinking ahead to basic airway management, I want to get some Goodell airways ready so that my bag mask ventilation will be more effective and I can always achieve oxygenation and ventilation. I've got here an end-tidal CO2 clip that's going to go on the end of my endotracheal tube once I've performed my intubation, hopefully detecting the presence of carbon dioxide, indicating that I have something in the trachea. I'm going to get some securing tapes ready, and we'll go through how we secure an ET tube. And finally, I want something that may be used if my intubation attempt fails. It's always a good idea. I always have an LMA on hand, or at least in quick reach, so that I know where this is. If my intubation's going poorly, I can have something to reference quickly. You may also want to grab a number of different masks if you don't know the size of your patient that may be adequate for bag mask ventilation. And you want to prepare your PPE as well. CRTO guidelines say that for any intubation attempts, we're going to be using gloves, mask, and eye protection, so goggles. You're going to do your own risk assessment as well to identify any other hazards that you may want to take extra precautions against. Okay, so now we've checked our equipment. The next thing we're going to do is move on to our patient and preparing our patient for intubation. First and foremost, verify that we have proper oxygenation. So if your patient is spontaneously breathing, a non-rebreather, so close to 100% oxygen, as close as we can get on a flow meter that's 15 liters per minute or flush, is adequate. If they're not spontaneously breathing, that's where you or your assistant is going to have to manually ventilate them for a minimum of 8 to 10 vital capacity breaths with your manual resuscitator. Possibly even looking at your saturation until you've optimized the situation. It's very important that you can establish nitrogen washout and pre-oxygenation prior to an attempt. Positioning your patient, you're going to want to put them into that sniffer's position. So extend the neck a little bit, do the chin lift. If required, you can use an assisted roll to help get your patient into that alignment so the pharyngeal and laryngeal planes align. And lastly, you want to look at your operation of an intravenous and your monitors. So it's very important we have a working intravenous so that we can give our pharmaceutical agents that are going to help us with our induction and possible paralytics for intubation needs. ATS criteria, so that minimum we want 380 ECG, non-invasive blood pressure, and a saturation probe that you can see we've got on our monitor here. Once you've prepared all of your equipment, you've prepared your patient, and you're satisfied with the operation of your intravenous and your monitors, at this time it's appropriate to prepare everybody else that's going to be your assistant for the intubation attempt. It's usually a physician, a nurse, and a respiratory therapist, and the roles will be delegated or assigned prior to, and be very informed of what your role is and what you're going to do as either the intubator or as the assistant.
What happened?
That's not.
This video is way longer and way more interesting. Any questions about setting up for intubation? You understand you can't put the tube in.
Alright.
There's no way down.
There's meant to be a 4 or 5 minute review of how do we intubate your normal, healthy, average looking airways? What kind of tools do we use? What kind of communication are we looking for? What are some anatomic structures we want to be able to identify and communicate to the airway team? what's being seen. So let me start out by showing how we grade airways. After you do a laryngoscopy, you can see a variety of views. You know, it depends on the technique, and it obviously depends on the airway. But the final view that you see, we try to classify on this scale from 1 to 4. One there you see on the left is a wide open airway that you can easily see the vocal cords. Top to bottom, you see the epiglottis, and this is about as normal as it gets. Over on the extreme grade 4 airway, all you really see is the base of the tongue. You don't see any arytenoids, you certainly don't see any vocal cords. Really, it's a terrible view because you can't tell where the esophagus is and where the vocal cords are. In between there, you have a grade 2 and grade 3. The grade 2 airway, you can still see some of the vocal cords, but not all of the vocal cords. There are some classifications that will actually further divide grade 2 into 2A and 2B, but for this purposes, if you can see all of those vocal cords, it's a grade 1. If you can only see some of the vocal cords, it's a grade 2. Grade 3 is you only see the arytenoids, and here you'll see the arytenoids just below this epiglottis. This is the epiglottis, just below that is the arytenoids, and then just above the epiglottis is the lecula, and above that, orbital basis. So this is the different views that you might see. So when you're asked what kind of views you have, you say it's a grade 1, it was a grade 2, also some of the vocal cords. Obviously, depending on your technique, you might be able to tweak things a little bit and turn a grade 2 view into a grade 1, or the grade 4 into a grade 2. So sometimes it's the provider dependent. Sometimes it's just the airway, and you'll never get anything better than the grade 4. Let's look at the tools that we use. Here are the two fundamental blades that we use. Two basic blades, the Mac and the Miller. There are other types of blades. And again, this is not intended to be an exhaustive review of pros and cons of each. But suffice it to say, we use two different types. We have a Mac blade.
Pay attention, this is critical. Someone says, give me a Miller, you need to know what a Miller is. It's not a beer.
Additionally, the Mac blade is intended to be inserted.
And the Mac is not a computer, named after fruit.
Whereas the Miller blade,
What?
the tip is intended to,
as long as the left-handed screwdriver.
To be right to get a better view of those cords. In the videos I'm going to show you, we'll look at the quote traditional way of using a Mac, but then we're also going to see a video where the Mac blade is used to lift the epiglottis, and we're going to look at the view where the Miller blade is put the molecula, and you can see the epiglottis. So there's nothing in stone about how these are to be used. But it's good to know that at least the names, the Mac and the Miller, the Mac is the curve, the Miller is the straight blade. Let's look at some videos.
And the Miller's a straight blade, the Mac is a curved blade.
Yeah.
This first one, we're going to take our time.
And there's also a curved blade called a grand view.
Through that, highlight some of the anatomic structures. And the subsequent three.
Don't ever stick your finger in someone's thumb like that. Dum dum dum
So here,
dum
our
dum
first
dum dum.
endoscopy video. We can obviously.
They see is that thumb is bye-bye.
And the CRNA has already put in this case, it's a Mac blade into the airway, and they're holding the airway open with the finger there. And I'm just going to go down the airway with a fiber optic scope so that we can see some of these anatomic structures and make some points. The first thing you see here is be careful on the teeth. Here it's obviously touching, but there's no force being generated on that tooth. You just want to be careful not to create leverage. You really want ideally space to be in between the laryngoscopy, the laryngoscope, and any kind of any teeth. You also should see up here in the upper right hand, you really don't want to see the tongue hanging down there. You're going to see how this obstructs your view and make difficult airways impossible, and it makes easy airways more difficult. So good technique all the time is what we prefer. And that includes going all the way down the right gutter of the patient's mouth and then sweeping the tongue all the way to the left so you don't see any tongue moving out there. As we proceed down into you can see right here, you can see how that tongue really obstructs your view. Behind the tongue, you know it's a great view. So in this case, it's okay because they had a grade 1 airway to begin with, so it's not an issue. But again, just better technique is to make sure that tongue is completely out of the way. Here you see the vocal cords hiding behind there. As you get behind the tongue, you're going to see two tonsillar beds. This particular child obviously has very small tonsils, which is excellent. You can see the uvula here at the bottom of the screen. But as you go a bit further in, You can obviously see the vocal cords up there.
So much bigger the
You can see
esophagus
that
is, the
this
vocal
a
cords.
back blade
Really easy to
directly
accidentally put the tube in the esophagus, then you kill the
so that
patient
area
if you
just
do
above
that.
the epiglottis.
And
The
then it
epiglottis
has
is
to put it
pointed
inside the
out,
vocal
you can
cords.
easily see it. And then you can see, obviously you don't get in this close, but typically that you can see a very straight on view of what we call the grade 1 airway, where you easily see the epiglottis, you see the full cords, you see the rhythmoid just beneath the cords. It's really a great view of open cords. One of the keys in any intubation is communicating with the other people around you. So what typically happens is folks that are learning to do intubations tend to be very focused on what they're doing. They forget that there's a team around them that are there to help, and they do it in silence. And so I think some reassuring words to always hear from whomever is doing the laryngoscopy is to say things. For example, I see the vocal cords. You'd be surprised if lots of folks will just do silent intubations and everyone else.
It's important to communicate. One of the coolest things I ever had was we had a guy that went into full cardiac arrest while he was eating. And he was eating alphabet soup, but when I put the blade in there, floating in the back of his pharynx were the letters from the alphabet soup, and it actually said HELP. And I wish I could have got the picture like this guy got. It was amazing. What are the chances of that really happening?
That's,
None.
No, it didn't really happen.
oh, one time you ever got me.
Are you serious?
I'm like.
That's ridiculous. Of course that didn't happen.
ABC first. Remind you to do
Yeah,
it.
so I'm saying, see, vocal cords, and say that.
2 hours is it, okay?
That was all. I've heard this so many times. Why am I being tortured?
That, you understand the semantics, vocabulary.
This guy's boring as hell.
Most of
Yeah. Wait, it makes us. Yeah.
Pause there, so you can see it. Let's take a closer look. As you come in, here you will see, here's a great example.
It's kinda cool, though.
Tonsils.
It's a little terrifying. They let paramedics do
It's not
this.
too big. You see vocal cords. Don't see enough of.
All right, you guys got any questions?
No.
Be careful eating alphabet soup. All right, so this one is an hour long, which we're not going to watch it right now. All right, so what? Well, the end for the presentation. Now we're going to go over all the equipment. Actually, we don't use whole beans on any of the equipment. That was like back with leeches and stuff like that.